This presentation is meant to inform the public on the correlation between obesity and total knee replacement. Some key terms and abbreviations. TKR stands for total knee replacement. BMI stands for body mass index. PSG is a patient-specific guide. Bariatric surgery is for weight reduction. Obesity is defined as 30 kilograms per meter squared. And osteoarthritis is the number one cause of total knee replacement.
A person can be grouped into one of 6 classes of BMI. The first class is underweight, which is people under 18.49 kilograms per meter squared. Normal weight is between 18.5 and 24.9 kilograms per meter squared. Overweight is 25 to 29.9 kilograms per meter squared. There are 3 classes of obesity. Class 1 is 30 to 34.9 kilograms per meter squared. Class 2 is 35 to 39.9 kilograms per meter squared, and Class 3 is over 40 kilograms per meter squared. This graph shows a comparison of obesity profiles of the U.S. population and patients of total joint replacement clinics. As you can see from the graph, there is more obese people in clinics than there are in the U.S. Only 34.9% of the U.S. population is obese, while 54.5% of patients that walk into total knee replacement clinics are obese.
One of the problems with obesity is the fact that it increases risks and complications of total knee replacement. Malalignment is a problem that occurs when the knee is more than 3 degrees off the mechanical alignment. The extra weight increases stress on the replacement parts, which can alter the angle post-operatively.
Being classified in Class 2 or 3 obesity can increase a patient's likelihood for developing an infection. This graph shows the cumulative incidence of infection per person year for 5 different groups of BMI. As you can see, the top 2 lines are significantly higher than the others. This is because Class 2 and 3 obesity have an increased chance of infection greater than the other weight classes.
Also, the Class 2 and 3 obesity can lead to slower recovery time post-operatively and a decreased range of motion that limits the function of the knee to subpar levels. The functional range of motion of the knee must be greater than 100 degrees for the knee to have adequate knee function. Obese patients tend to have less than 100 degrees of motion. This causes inadequate and subpar function for the knee.
To solve these problems, medical professionals have come up with a couple of options for patients. Some treatment options include patient-specific guides or bariatric surgery 2 years prior to the total knee replacement surgery. Patient-specific guides have been found to help obese patients with total knee replacement because they create custom components for the knee replacement instead of using a one-size-fits-all like they did in former treatment. Bariatric surgery 2 years prior to total knee replacement is supposed to speed up the recovery. This is why it can be considered a cost-effective measurement because it increases quality adjusted life years. However, new research has shown that bariatric surgery prior to total knee replacement does not increase the recovery time. So further studies must be conducted to conclude whether bariatric surgery is a good option for overweight and obese patients. To increase information in this field, we must shine light on this topic. That way, future patients that are obese can have proper treatment when undergoing total knee replacement.